All. As Ma'am Senior said, today we are going to learn about management of pain. Last week we have learned about how to assess pain, what is pain, what are the different types of pain and all. Today we have Dr. Mary Abraham with us. She is a palliative care physician and a neuroanesthesiologist. She is in New Delhi now. She is a visiting consultant in Max Hospital, New Delhi, and Indian Spinal Injury Center, New Delhi. And she has received a award from Lifetime Achievement Award from Delhi Neurological Association in 2017, and she has written a book on conquering pain. She has a lot of experience in palliative care and especially pain management. Madam, welcome and over to you, ma'am. Happy to see you.
Thank you, Shiva. Thank you, Shri Priya, right? Today?
Yeah.
Okay. Am I audible?
Yes, ma'am, you are.
Thank you so much for the kind introduction. And it's a pleasure to take this talk for all the nurses today on the WHO Step 1 and Step 2 drugs with something about neuropathic pain and adjuvant drugs. Can I share the screen, please?
You have sharing rights, ma'am.
Okay. Okay. So I will be talking about the WHO. I told you this is a 1 minute. I just put it on. The broad outline of my talk is basics of the WHO analgesic ladder, focusing on the step 1 and step 2 drugs, and a little bit about adjuvant drugs and the drugs for neuropathic pain in particular. Now, to start with, it is important to know that pain management, access to pain management is a fundamental human right. And this was reiterated in the Declaration Montreal, which took place in 2010, in which it was documented that it is a right of all people to have access to adequate assessment and treatment of pain by trained healthcare professionals. So just like we have so many fundamental rights, like right to health and right to speech, right to religion, so like that, even access to pain management is also now deemed a fundamental human right. So according to the international human rights law, countries have to provide pain treatment, medication, as part of their core obligations under the right to health. And in fact, it is said that failure to take reasonable steps to provide pain relief is deemed cruel, inhuman, and degrading. And particular cancer pain has also received a big impetus, with the WHO making out various policies and strategies to treat cancer pain with an emphasis on total pain management. I suppose you must be knowing what is total pain management, because it must have been earlier told to you. So it is not just the physical pain, but we also treat the psychological pain, the social pain, and the spiritual pain as well. So now coming to the WHO analgesic ladder, this was devised in 1986, more than 30 years ago. And this was devised to manage cancer pain. And it was based on the recommendations of a group of international experts. And subsequently, over the years, it has been translated into 22 languages, and it has been widely used to treat cancer. Now, this is a very simple, well-validated and effective tool. And it is a stepwise approach to treat cancer pain depending upon the severity of pain. So it is very important to assess the severity of pain, and based on that, you can apply the ladder to the and treat it accordingly. Now, before the ladder, that is before 1980s, people were dying in unnecessary pain for two reasons, or many reasons, but the two reasons were that opioids were not being freely given because of so many drug regulations associated with prescribing opioids, storing opioids in the hospital, and even the people taking opioids also. So because of all these drug regulations, very stringent laws were there. So because of that, there was a lot of hesitancy in prescribing opioids. Secondly, there was also stigma associated with the taking opioids. People were thought they will be called addicts, morphine addicts. So because of the stigma, people, even the relatives did not want to give morphine to their persons who are having pain, thinking that he will become dependent on it and addicted to it. But when the WHO ladder was devised by an organization like the World Health Organization, where they said that you can take strong opioids in severe pain, this legitimized the use of opioids, and the laws also became a little more easy to follow. And the stigma that, if you take morphine, you are called an addict, all that became much less after the making of the WHO analgesic ladder. So let us start with a case scenario to understand how we apply the ladder in this particular case. This was a 35-year-old father of two young children. He had a CA of the upper lung, lobe of the lung, right lung. Now, the pain he had was, he had a gnawing, deep-seated, sharp pain in his right shoulder, along with burning and tingling sensation in the right arm. He was unable to sleep, and while the pain score was at 4, NRS 4 in the morning during the day, at night it went up to NRS 6. That is a numerical rating scale was 6 at night and 4 in the morning. So when you want to apply the ladder, first of all, we need to assess the pain. So there is this mnemonic to assess pain, which is PQRSTUV. I think this has been dealt with earlier. But out of this, we have to focus on the severity of the pain or the intensity of pain. So what is the NRS scale? Is it 4? Is it 6? Is it 8? Is it 10? And based on that, you can apply the ladder. Also, we need to know, there are other factors like temporal factors. That is the pain more in the daytime, more at night? How long has it been lasting? So the time features, how is the pain related to time? That is also, we can find out. The other thing we need to do about the pain is it nociceptive or is it neuropathic? Now, nociceptive pain is because of tissue injury. I'll talk about it in a later slide where I will show you a diagram about it. And neuropathic is pain due to nerve injury or injury in the central nervous system, whether it's a spinal cord or in the brain. So anything beyond the tissue, level is called neuropathic, but at the tissue level, it is nociceptive. So this is very important to know whether the pain is nociceptive or neuropathic, so that we can apply the ladder properly. Now coming to the ladder itself, we have a 3-step ladder, is the one that is generally followed. In step 1, it is used to treat mild pain, where the NRS scale is around 3 to 4 or not more than 4 or 5. So in this, we can give a non-opioid analgesic with or without an adjuvant. I'll talk about it a little later in detail. Now, if it is not responding to this, then you move up to the step 2, where the pain is usually moderate in nature, which means the NRS would be between 5 to 7. In such patients, in addition to the non-opioid with adjuvant, you add a weak opioid. Okay. And you can combine it with a non-opioid and an adjuvant. If it is not responding to this also, then you move up the ladder and you go to step 3, in which you give a non-opioid and adjuvant as usual, but you add a strong opioid like morphine or methadone or something like that. So this is how you move up the ladder. Sometimes people come in very severe pain right in the beginning, and when the scale is around 8 to 10, and then sometimes you may have to omit the previous steps and directly go to the step 3. But of course, you have to do what is called an morphine titration and then give it. You can't directly give like that. So this is the basics of the WHO step 3 ladder. And using this ladder, we can control up to 71 to 76% of patients with cancer. So just using this ladder, you can control 3/4 of patients with pain and cancer. So what are the salient features of the ladder? The first important, please remember three things: by mouth, by ladder, by clock. They are very, very important, the ladder. So what is by mouth is all these drugs of the WHO analgesic ladder is given orally. That is the standard route of administration. Even for the strong opioids, even the step 3 drugs are given orally. So the advantage is it is very suitable for home care. The visiting nurse can give it, the caregiver can give it, and if the patient is fully conscious and they themselves can take it under the guidance of the caregiver or the nurse. So that is a big advantage in that we don't have to give it parenterally, that is either subcutaneously, intravenously, or anything. The second important feature of the WHO analgesic ladder, it is by the ladder. I told that you start with step 1 and then you move up the ladder to step 2 and step 3. But occasionally you may have to skip a step and go on to the next step. The third important feature is that it is given by the clock. Now, this is very, very important to explain to the patient. That by the clock means we are giving it according to the duration of action of the drug and not giving based on the pain occurring. Okay. So many times people wait for the pain to come back and take the drug, which is wrong, because when the duration of action of the drug is over, the pain will come back. And then treating the pain means the patient will not be comfortable because there are a lot of ups and downs. So you need to control the pain 24/7. And to do that, you need to give it according to the duration of action of the drug. For example, morphine's duration of action is only 4 hours. So at the end of 4 hours, you have to give the drug whether the pain has pain or not, patient has pain or not. Or for paracetamol, it is given every 6 hours. So many drugs are there based on the duration of action. You have to give the drug. That has to be clearly spelled out to the patient. They have to keep a clock. In fact, you can write the time also. Like you're giving at 6 in the morning, the next dose is at 10, then the next dose is at 2, and the next dose is at 6, and the next dose is at 10. So you tell them, you make a chart according to the time, and then according to the time, you give the drug. Another important feature of the ladder is it is individualized to the patient. That means the right dose of drug is that which is controlling the pain. So supposing one patient may require only 30 mg of morphine. Another patient who has more severe pain may require 120 mg of morphine. So both are right as long as the pain is controlled. So that all depends upon the individual, the type of cancer they have, the extent of the metastasis that they have. And also we have to talk about, supposing in that particular time period, say for morphine, it is 4 hours. At the end of 2 hours, the patient is again having pain. Then we say that this is called a breakthrough pain, and you can give another bolus dose of morphine. So all that has to be spelled out to the patient. So it is basically individualized to the patient. So all this has to be told for the patient to have good relief of pain. Then there is the use of adjuvant drugs. This is added at every step of the ladder. Step 1, step 2. And these drugs can be given for different types of pain associated with cancer. I will talk about it later. And also to decrease undesirable effects of certain of the analgesics that you give the step adjuvant drugs. Then a lot of attention has to be patient, to detail has to be noted. For example, the patient's age. Is he an elderly man? Is he emaciated? Does he have any comorbidities? So according to that, what are the side effects of the drugs? So we need to monitor everything very, very carefully so that the patient is not having any undue side effects. Okay? So these are the salient features of the WHO ladder. So what are the advantages of the ladder? That is, it's simple, it is easily understandable, it's a validated tool. That means it has been proven to be effective when you give it according to that ladder. And it's also very cost effective. Most drugs of the analgesic ladder are relatively inexpensive. So it does not work out to a much of a financial burden to the patient. And it can be implemented across the world, even in remote and underdeveloped countries. Well suited for home care because most of these drugs are given orally. And it is also, you can use it for non-cancer pain as well as for acute pain, like pain of appendix or pain due to a fracture or pain due to post-operative pain. No? This acute pain. You can even give in for acute pain. So if you look at the ladder, this is a 3-step ladder. The first step, you give non-opioid with adjuvant. Second step, you add a weak opioid. And the third step, you add a strong opioid. Now, there are some modifications of the ladder which has been done over the years. Sometimes from step 1, you can directly move up to step 3. If it's not controlled well, you need not give the step 2 drugs. You can go to step 3 if the pain is very severe. Sometimes you may add a 4th step to the ladder. And that is done when they are not responding even to step 3 drugs. I'll talk about in my next slide. So this is the modified WHO analgesic ladder, which came out in 2000. And this was, like I said, 10 to 15% of patients are not responding to the step 3 drugs, right? To the morphine also. So there you can add the step 4. You can give a nerve block. You can give epidural injections or patient-controlled analgesia pumps. You can do a neurolytic block, like a celiac plexus block or a splanchnic nerve block. Or you can use spinal cord stimulators, or you can even put in an intrathecal pump to give morphine. So these are all invasive measures which you can do if the patient is not responding to the strong opioids as well. Now let's discuss step 1 drugs. So I said step 1 is used for mild to moderate pain, and they include paracetamol, non-steroidal anti-inflammatory drugs or NSAIDs, and they can be combined with an adjuvant drug. So let's discuss paracetamol. Now, paracetamol is a name used in India and Europe, and America it is called acetaminophen. Okay, they are the same drug. This acts by a central action, that is, it inhibits the enzyme cyclooxygenase in the central nervous system. It has no effect on peripheral cyclooxygenase. Please remember that all the NSAIDs are acting on the peripheral cyclooxygenase enzyme, and that is why they have so many side effects. So paracetamol basically has an antipyretic and analgesic action, but it does not have an anti-inflammatory. What is a dose of paracetamol? You can give up to a dose of 3 grams a day. The daily dose should not exceed 4 grams, and a single dose should not exceed 1 gram. You can give a paracetamol infusion also sometimes in a dose of 1 gram every 6 hours. Now, paracetamol is known to cause hepatotoxicity, but that occurs when you give doses which are more than 3 to 4 grams a day. And in such patients, you can restrict the total dose of paracetamol to 2 to 3 grams. So that can be given even in patients with liver dysfunction. In pediatric use, it is very safe in a dose of 15 ml per mg per kg every 6 hours. Toxicity only occurs when you give more than 4 grams a day or in doses more than 90 mg per kg per day. Sometimes when you cannot give it orally, like in patients with oral cancers or head and neck cancers, then you can even give it rectally as well. What are the advantages of paracetamol? Here, it has a very good safety profile. Now, if you compare with NSAIDs, NSAIDs has got a lot of undesirable effects. So compared to that, this has a very good safety profile, and it has no adverse effect on the gastric mucosa. It's tolerated by patients with peptic ulcers or who are having acid peptic disease. It does not have any adverse renal effects, no adverse effect on platelet function, so no chances of bleeding problems. And it is even tolerated by patients who are sensitive to aspirin. We know that aspirin can cause hypersensitivity reactions, so that does not occur with paracetamol. And also, it does not affect the plasma uric acid level, so it can be given in patients with gout. But there are some drawbacks of paracetamol. One is that it has to be given every 6 hours. So increased frequency of administration. It has a potential for hepatotoxicity, but that occurs when you give doses of more than 4 grams a day, when there's already impaired liver function, when there's alcohol consumption, heavy alcohol consumption, or if the body weight is less than 50, then you restrict the total dose of paracetamol to 2 grams only. In cancer pain, it is a mainstay drug for the WHO ladder, given at every step of the ladder. You can combine it with NSAIDs and tramadol or opioids. It has a very good safety profile, and it has also got an opioid sparing effect. So when you add paracetamol to the morphine, it can actually decrease the total dose of morphine that we are giving. That is called opioid sparing effect. Now we come to the next drug of the step 1 drug, which is a non-steroidal anti-inflammatory drug. So this is very commonly available over the counter. We do not even need a prescription to get this drug. The advantage of this over paracetamol is that it has also anti-inflammatory properties, which paracetamol doesn't have. So it's a very good analgesic with anti-inflammatory properties, mainly used for nociceptive pain, that is pain due to tissue injury like inflammation or cancer or anything. Sometimes we can even give it for neuropathic pain as well. How do NSAIDs act? NSAIDs acts on the peripheral cyclooxygenase. You remember I told you that paracetamol acts on the central cyclooxygenase? This acts on the peripheral cyclooxygenase. Now, when tissue injury occurs, there's a release of a lot of cell membrane products like phospholipids and all into the circulation, into the tissues, and that is actually ultimately produces tissue prostaglandins, and that occurs because of the arachidonic acid pathway. And these prostaglandins are the ones that are causing pain and inflammation, and it is especially seen in nociceptive pain. So if you look at this chart on my right, see, tissue injury leads to the release of phospholipids from the cell membranes and from the cell, and this is converted into arachidonic acid. And this arachidonic acid is acted upon by the cyclooxygenase enzyme and converted into the prostaglandins, which is causing this inflammation and pain. So this is called the COX-2 enzyme, and it is released only when there is a tissue injury. But we have another COX-1 enzyme, which is an enzyme present in the body, present in the stomach lining, in the kidneys, among the platelets. And this is called a housekeeping enzyme because it is essential to maintain the physiological function of the stomach, the kidney, and even the platelet aggregation. So this enzyme is very important for the proper functioning of the stomach, the kidneys, or the platelets also. Now, when you give a drug like a non-steroidal anti-inflammatory drugs, we actually wanted to block only this one. But because it is a non-selective NSAID, it is even blocking this, causing the side effects. Because when this enzyme is blocked, then these functions are hampered. Okay? So there are two types of NSAIDs. The one is a non-selective, which is inhibiting both COX-1 and COX-2. And the selective COX-2 is interfering only with the COX-2 and it is not touching the COX-1. So if you look at the non-selective, the examples are ibuprofen or brufen as we call it, naproxen or aspirin. Like I said, it's inhibiting both COX-1 and COX-2. Because it is inhibiting COX-1, it is causing the adverse effect on the stomach and the kidney and the platelets, right? So it causes bleeding from the stomach, allergy, anti-bronchospasm, and even kidney dysfunction. But because it is blocking the COX-2, it is exerting its anti-inflammatory, analgesic, and antipyretic effects. So that is beneficial. So non-selective NSAIDs is a double-edged sword. It has got both adverse as well as the beneficial effects. Now coming to the non-selective NSAIDs, like I said, the examples are ibuprofen, which is given orally in a dose of 400 mg every 6 to 8 hours, or naproxen, which is given in a dose of 250 to 500 mg every 12 hours. So these are some of the examples. Even aspirin was given in a dose of 350 to 500 mg. Now, what are the side effects of these non-selective NSAIDs? Because of the COX-1 inhibition. Remember, I told you that is important for that. So it can cause adverse renal effects, it can cause bleeding and ulceration from the GIT, or it can cause hypersensitivity reactions on the skin or the respiration. Now, selective COX-2 inhibitors are inhibiting only COX-2 enzyme. The COX-1 is not inhibited. So it is actually theoretically preventing the adverse effects of the COX-1 inhibition. So the examples are etoricoxib or Nucoxia in a dose of 60, 90 or 120 mg once a day, or celecoxib in a dose of 100 mg or 200 mg twice daily, or diclofenac, which can be given orally or intravenously in a dose of 50 mg every 8 hours. So the question we need to ask are selective COX-2 inhibitors safe as compared to non-selective inhibitors? Now, where the GIT is concerned, definitely the selective COX-2 inhibitors are safe. So you can give them in people with who are already having acid peptic disease. But where renal damage is concerned, it does not have an advantage over the non-selective NSAIDs. But the main disadvantage of these non-selective NSAIDs, selective COX-2 inhibitors, are that it is a prothrombotic. So in people who have got atherosclerosis, like cardiac or cerebrovascular disease, they can get myocardial infarction and stroke because of its prothrombotic effect. So the selective COX-2 inhibitors can have this disadvantage of causing MI and stroke. In fact, one of the selective COX-2 inhibitors like rofecoxib was taken off the US market in 2004 because of the incidence of stroke and MI. So what are the precautions we need to take when we're giving NSAIDs? Always give it with a gastroprotective drug like a proton pump inhibitor like pantoprazole or omeprazole. Caution should be given with patients with acid peptic disease, and please ensure adequate water intake. Avoid dehydration to prevent renal damage. If there's a bleeding tendency, then you should avoid it. And we have to particularly note that those with atherosclerotic disease like CAD or cerebrovascular disease, we should avoid the COX-2 inhibitors. Now, these are also available as local gels and creams, the non-steroidal anti-inflammatory drugs. So they can provide the analgesic effect without much of systemic absorption and less chances of toxicity. So you have various gels and creams containing ibuprofen, diclofenac, piroxicam, or ketoprofen. So these are the risk factors for GI toxicity. I've mentioned it earlier. Those with upper GI symptoms and bleed, you should avoid it. Also those with advanced stage. And again, when there's dehydration or when the patient is already taking nephrotoxic drugs, or if the creatinine clearance is very less, you should avoid it. And COX-2 drugs you should avoid in patients with hypertension, hyperlipidemia, diabetes, because they are prone to get the cerebrovascular and cardiovascular disease. So you have to avoid COX-2 inhibitors in such patients because there's a chance of stroke and MI in them. Now coming to the step 2 drugs. Now these drugs are used to treat moderate pain, and you can combine it with a non-opioid as well as an adjuvant drug. Now these drugs, although they are weak opioids, they are not controlled drugs, which means we do not need to give it a special prescription. And they are given for pain of moderate intensity, which is not controlled with step 1 drugs. And sometimes you may have to skip the step 2 and go up to step 3. And the examples of this step 2 drugs are tramadol and tapentadol. We also have codeine and dextropropoxyphen, but then we are not talking about it because it's not available in our country. Now coming to tramadol. Tramadol is a centrally acting drug. It is a weak opioid agonist, and that is how it's exerting its analgesic effect by because it's a weak opioid receptor agonist. Secondly, it also blocks the presynaptic reuptake of serotonin and norepinephrine. And because it's a weak opioid, there's less tendency for respiratory depression and addiction also. And very often we are combining paracetamol with tramadol and using as a step 2 class. Now, tramadol has a high oral bioavailability. That means when you take it orally, about 90% absorbed. So it's got a high oral bioavailability. And the oral dose is very potent. It's 1/10 as potent as morphine. So when you're giving morphine, say 40 milligrams, it is equivalent to 400 mg of tramadol. You have to divide that tramadol dose by 10 to get the equivalent of morphine. Okay. How do you give it? You give it in a dose of 50 to 100 mg every 4 to 6 hours. Maximum daily dose should not exceed 400 mg. Now, sustained release formulations are also available. So you need to give it only twice daily, like tramadol SR or tapentadol SR and all are available. But it has got some side effects like nausea, vomiting, dry mouth, constipation, dizziness, sedation, and particularly it can lower the seizure threshold. So please be careful when we give it in patients with epilepsy and those with TC. It's not that it is contraindicated, but we have to use it with caution. The other step 2 drugs are tapentadol. It is similar to tramadol where the mode of action is concerned. That is, it is a mu receptor agonist, and it is also acting on the inhibitory pathways by preventing the reuptake of serotonin and norepinephrine. Its side effect profile is slightly better than tramadol. The dose is also similar to tramadol, 50 to 150 mg every 6 to 8 hours in a total dose of 400 mg per day. Sustained release formulations are also available with tapentadol. So if you look at the combinations that we can give of analgesic of the WHO ladder, never use 2 drugs of the same category. For example, we do not combine COX-1 and COX-2 drugs. Also, we don't combine a weak opioid with a strong opioid. And then the combinations that are safe are paracetamol with NSAIDs along with morphine, or paracetamol with NSAIDs, or paracetamol with tramadol. These are the safe combinations. Now coming to the adjuvant drugs. Now cancer pain is multifaceted. It is just not a nociceptive pain, but there can be bowel obstruction pain, bone pain, neuropathic pain, other symptoms, as well as muscle spasm. So that is where the role of adjuvant drugs are coming into the picture. So adjuvant drugs have, the primary indication of adjuvant drug is not pain. For example, when you give an antidepressant, the primary action is probably for depression, but they have analgesic properties as well. That is why it is called a co-analgesic. That means it's given along with a drug of the WHO analgesic line. So when you want to classify these adjuvant drugs, we have a multi-purpose drugs. That means it can be given for a variety of conditions, and they include antidepressants, corticosteroids, alpha-2 agonists. Then you have neuropathic pain drugs. Then you have bone pain drugs. Then you have adjuvants for bowel obstruction or adjuvants for musculoskeletal pain. So this is a broad classification of adjuvant. I'll go through some of these more deeply. Now, neuropathic pain. Now, neuropathic pain occurs in 40% of patients with cancer. It is not just tissue injury. The nerves and the nervous system is also involved. So the definition of neuropathic pain is pain caused by a disease or lesion in the peripheral or the central nervous system. And how do you distinguish that the patient has neuropathic pain? Because a pain can have a burning sensation or a shooting or electric current, or there could be allodynia. Allodynia is simply touching the skin causes pain. That is called allodynia. So that is when we say that the pain is neuropathic in nature. So if you look at the pain diagrammatic representation of the pain pathway, here you have the tissue where the peripheral nerve ending is there. So any injury over here will cause called a nociceptive pain. But anything beyond this, that is the peripheral nerve, the spinal cord or brain. So any lesion in this will cause what is called a neuropathic pain. And sometimes this pain can be both nociceptive as well as neuropathic. It's called mixed pain. So very often they have a mixed pain in which there is both nociceptive and neuropathic element. So why does neuropathic pain occur in cancer? It's because of the cancer invading the nerves or compressing the nerves, okay? Or it could be because of the treatment of cancer by chemotherapy, radiotherapy, or surgery. So chemotherapy, when it damages nerves, it's called chemotherapy-induced peripheral neuropathy. Or it could be radiation-induced neuropathy. Or it could be neuropathy due to injury, the cut of the nerve during surgery. And sometimes this can even occur in cancer survivors where the cancer is cured, but the neuropathic pain will remain. That is, the peripheral nerves continue to be damaged and in pain. So the first line treatment for this is anticonvulsants. And the most commonly used anticonvulsants are pregabalin and gabapentin. So if you look at the advantages, it has got effective in neuropathic pain and well tolerated. And the side effects are sleepiness, dizziness, ataxia, fatigue, weight gain, and impaired concentration. So the two commonly used drugs are gabapentin and pregabalin. Gabapentin is less expensive, but you need to take multiple steps to get the correct dose. Whereas in pregabalin, in just 2 to 3 steps, you can titrate to the correct dose, but it is more expensive than gabapentin. Now coming to antidepressants, this is a first line treatment for neuropathic pain, just like the anticonvulsants. Its analgesic action takes a week to start, and it occurs much earlier than the antidepressant effect, which occurs later and also at higher doses. The analgesic effect occurs at much lower doses than what you give for depression. But because many cancer patients have got depression, anxiety, insomnia, these drugs are very useful because they also act like antidepressants. So the main antidepressants used in cancer pain are the tricyclic antidepressants like amitriptyline or nortriptyline or tryptomer, like it's called, amitriptyline. Or you have the serotonin norepinephrine receptor inhibitor, the SNRI class. The example is duloxetine. And then you have the SSRI or the selective serotonin receptor inhibitor. The example is escitalopram. Now, this tricyclic antidepressants, or TCA it's called, has got some side effects. The CNS effects are somnolence, that is drowsiness, mental clouding, even suicidal tendency. And the other anticholinergic effects of TCA include dry mouth, acute angle glaucoma, blurred vision, tachycardia, urinary retention, constipation, and orthostatic hypotension. So you should avoid using TCA in patients with heart disease, those with prostatic hypertrophy, and those with glaucoma. Now coming to the SNRI drugs, again the same thing: somnolence, dizziness, constipation, anorexia, decrease in sexual function, etc. And the contraindications are, whenever there is a duloxetine is particularly avoided in patients with liver insufficiency. So the dose of duloxetine is given here, and the dose of venlafaxine. These are the SNRI drugs. So if you look at the dose administration, when you start amitriptyline, you start with a dose of 10 to 12.5 mg, and you gradually step up to every 3 to 5 days. And gabapentin, you can start with a dose of 100 mg or 300 mg and then gradually step up. And pregabalin, you start with a dose of 75 mg. Now, people with medically ill patients, those with renal dysfunction or with comorbidities, you need to adjust the doses accordingly. What are the other drugs that we use in neuropathic pain? The other category is the NMDA. They are not the first line drugs. They're used only when it is not responding to the first line drugs like antidepressants and anticonvulsants. So NMDA antagonists are given. Example is ketamine. Now, I showed you about this diagram. So here, this is the peripheral nerve ending where the tissues are there. And then you have the peripheral nerve. And in the spinal cord is what is called the NMDA receptor. And these drugs are blocking this NMDA receptor and preventing the perception of the neuropathic pain. So ketamine is actually an anesthetic drug. But in sub-anesthetic doses, it is good for neuropathic pain as a third-line treatment, not as a first-line treatment. The dose of oral ketamine is 10 to 25 mg TDS. You can give it as subcutaneous or intravenous infusion in a dose of 50 to 100 mg per day in a syringe pump. Of course, you should monitor the patient during the administration of subcutaneous or intravenous ketamine. It's always given in a hospital setup. Sometimes patients are not responding even to this. Then you can give what is called a burst ketamine dose, when you have to put in a syringe pump and monitor for 3 to 5 days. So that is only given when the pain is not responding to the regular doses of ketamine. But it has got some side effects, mainly dysphoria, agitation, hallucinations, nausea, vomiting, etc. So you can add a benzodiazepine like midazolam or clonazepam, etc., to prevent these side effects of ketamine. Local anesthetics is also one of the drugs that can be given when it's not responding to the first-line treatment for neuropathic pain. And they decrease the excitability of the sodium channels, and it is only given in intractable pain, neuropathic pain. It can be given as a local anesthetic infusion. When you again do it in a hospital setup with cardiac monitoring, you add 5 milligram per kg Xylocard into 500 ml of saline and give it over 1 hour. And if the pain is controlled, then you can repeat it after a few days. Sometimes we even use local anesthetic lidocaine patches. They are now available in India. It's 5% patches. And you can use up to 3 patches a day. But just remember, when you put it for 12 hours, then the next 12 hours, you must remove the patch. Otherwise, they can have side effects due to the local anesthetic getting absorbed into the cell. So if you look at the neuropathic pain ladder, I said the first line drugs are amitriptyline, pregabalin or gabapentin, duloxetine, and even lidocaine patch. In the second line, you can use opioids and tramadol, opioids particularly methadone. Okay. And in the third line, you can use drugs like ketamine or capsaicin patch, etc. Now, corticosteroids. Now, this is a multi-purpose analgesic drug because it is used for a variety of pains in cancer. One is it can be used for neuropathic pain, in bone pain, in headache because of intracranial metastasis, due to organ, small bowel or large bowel obstruction, or even due to spinal metastasis. Its beneficial effects are, other than the reducing pain, it also improves the appetite, malaise, and nausea, and improves the quality of life of the patient. Mode of action, it is acting by decreasing the edema because of its anti-inflammatory effect and also because it's a mood elevator. But it has got side effects like it can cause adrenal insufficiency, myopathy, and immunosuppression. The steroid that we commonly use is dexamethasone or Dexona or Decadron. Okay, it's given in a dose of 4 to 8 mg once a day for 5 days. Its duration of action is very long. Half-life is 36 to 54 hours. So you can give only once a day. You don't have to give it more often. It has also got less mineralocorticoid effect, means less water and sodium retention. So that is why it is more preferred drug. The other steroids we use are prednisolone and methylprednisolone. So like this is a dose that we give it. But always remember that you have to combine it with a gastroprotective drug because it can cause ulcers forming, stress ulcers forming in the stomach. The other drug that we use for pain are GABA agonists like baclofen, especially when there is neuropathic pain associated with spasticity. So it can be given a dose of 5 to 10 mg and we can gradually step it up. For bone pain is because of the skeletal metastasis from cancers in the breast and lungs and prostate, multiple myeloma, colon and kidney, etc. And this is called skeletal related events, multiple metastatic disease of the bone. And it can cause very agonizing pain and it can affect the quality of life of the individual. So there are various options to treat bone pain. One is corticosteroids and NSAIDs, or you can use calcitonin is not given nowadays. The other drugs that is commonly used are bisphosphonates and denosumab. They prevent the bone resorption and allow the bone formation to occur, and thus reduces the pain, and also palliative radiation. So these are the bisphosphonates that we give, zoledronic acid. It is given intravenously. It is very cost effective, but there is risk of renal toxicity. And denosumab also acts by preventing bone resorption and allows bone formation to occur. It is maybe a little superior to zoledronic acid, and it has got less risk of renal toxicity, but it is more expensive. But the survival rate is said to be better with denosumab as compared to zoledronic acid. Now, palliative radiation can be done to the bone metastasis, and that is done using various nucleotides like strontium and samarium, which delivers radiation to the bone mets. And it can cause good pain relief. It preserves the function of the bone and maintains skeletal integrity, and it has got less serious side effects. But sometimes it takes a few weeks for its effect to come on. Now, pain due to bowel obstruction is there. So we have various adjuvants to treat that. They include steroids because it decreases the edema in the bowel. Then you can use somatostatin analogs like octreotide or anticholinergic drugs like hyoscine butyl bromide or glycopyronate. They act by decreasing the intraluminal secretions in the bowel and also decreases the peristaltic movement. Sometimes you need to combine all three to treat pain due to bowel obstruction. The other adjuvant drugs that we use are skeletal muscle relaxants like thiocolchidoside, like Myoril, tizanidine, fluoxetine, or you may have to use neuroleptic drugs like olanzapine when there is delirium or nausea, vomiting, or even for terminal sedation. Then we can use other drugs like laxatives, anxiolytics, sedatives. These are all the other kind of adjuvant drugs that we are using. Now coming to our case scenario. We talked about this gentleman who has CA in the right upper lobe with pain, which is in the shoulder as well as going down the arm. Now, it was Margot McCaffrey in 1968 who said that pain is whatever the experiencing patient says is existing whenever he or she says it does. So you have to believe the patient. When the patient says, I have pain. Now, if you want to analyze this patient, first we need to do a comprehensive pain assessment. You should elicit the pain characteristics. I told you about the PQRSTU. You must take the functional history of the patient. That means how much is he able to do his daily activities. Then you should review the drug history and also other treatments that he's taking and do a physical examination. And then very importantly, you have to do a psychosocial and spiritual history. That is, are psychosocial issues worsening the pain condition? If you look at the intensity of pain in this gentleman, he had only mild to moderate pain. That is 4 in the daytime and 6 at night. The pain was a combination of nociceptive and neuropathic. Nociceptive because he had a gnawing pain in his shoulder, and neuropathic because it was having a burning sensation in the arm. Okay. Then the temporal nature, it was worse at night and less in the daytime. And when you unveil the meaning of pain, then you can see that he is a father of 2 young children. He's unable to work and sleep. So there might have been functional, emotional, social, and financial considerations. So how do you manage it? We can try step 1 drugs along with adjuvant drugs for neuropathic pain and the insomnia element. So you can start off with paracetamol, with NSAIDs, with gabapentin and a sedative as well. And also we need to address the psychosocial support to address financial and social concerns. To summarize, WHO analgesic ladder is a sheet anchor for cancer pain management. It can also be used for non-cancer pain. It is very simple, easy to implement. It can be used all over the world, even in the remotest area. And it has legitimized the use of strong opioids in the treatment of cancer and non-cancer pain. That's it.
Thank you, ma'am, for the wonderful session. Anybody have any doubts regarding this session? Please ask, madam.
Shall I stop the screen sharing?
Yes, ma'am. Okay.
So any questions or doubts? Is it very clear, all that I said?
I hope so, ma'am.
There are no questions
doubts,
and doubts.
yeah.
It means everything is clear.
I think they have some doubts. Anybody have any doubt? Yeah, so
Hyperhidrosis.
I shall start.
Hyperhidrosis is excessive hair. Okay. And that can occur when you give steroids. Corticosteroids, no, you can get hyperhidrosis.
Any other questions?
So, I mean, is it very clear what I said about the WHO analgesic step 1 and step 2 drugs and the drugs that we use for adjuvant drugs? Is it clear? I think as nurses, you may be giving so many of these drugs, right? Many of you may be working in cancer setups where you may be giving drugs like dexamethasone or zoledronic acid. Who all have given zoledronic acid here in this group? Can you raise your hand? Because bone pain is usually treated with zoledronic acid, right? What is gnawing pain? So this question that what is gnawing pain? Gnawing is, you know, a rat when they actually gnaw because they're poking. Okay, rat, how does it create burrows and all? It's by gnawing. So gnawing pain is something that is all the time poking you. So it is a very sharp, localized kind of pain, which is typical of nociceptive pain, right? Because a pain in the shoulder was gnawing variety. That means it was a sharp, poking kind of pain. Whereas the pain in the arm was electric burning kind of pain. So that is more suggestive of a neuropathic pain. Any other questions? You can open your mic and talk. I mean, unmute yourself and talk.
Sonia? Sonia, you can unmute your mic and ask the doubts.
Yes, I wanted to ask regarding. I wanted to ask regarding this step ladder approach. Is this same as far as medicine is concerned in case of pediatric scenario as well?
Yes, in pediatric scenario also you can use this. Okay. Yeah, but of course the people should be experienced in using it for pediatrics. But always we can start with paracetamol definitely as a first line drug, and we can go up to morphine also in these people. Fentanyl, morphine, and tramadol, all can be given in pediatric patients. But of course, the person who's doing it should be familiar with pediatric usage.
Thank you, ma'am.
So any other doubts? I think no doubts, ma'am. So madam's presentation was clear, but we need to understand that nurses are not an authorized person for prescribing drugs, but we need to able to assess the side effects of medications and what are the maximum dosage and so what are the precautions which they have taken they if they prescribe if they are on NSID like Brufen or any NSID. So what are the precautions they might taken along with that medications that all you should know. Then only you have to talk to you can give a adequate explanation or instruction to the patient and the caregivers how to take. So for example, if they are on NSID, they should take NSID after food, and along with that they should take a proton pump inhibitor. Madam already said like that, and they have to take a plenty of oral fluids. So that type of instructions you have to give to the patients and the caregivers. So you should keep it in mind, at least one NSAID can cause acute renal failure. So this is very, very important. If the doctor prescribed NSAID for the patients, you should give a adequate explanation that the precautions and how to take medications and all you can give to the patient and their caregivers. That way we can able to prevent complications like this.
Yes, I think nurses should be very proactive, and they are many times. And sometimes even doctors are fallible. They can make mistakes. Okay. They may forget to write the proton pump inhibitor. Then you can tell the doctor also, that see, you have not written that, or the patient is dehydrated. So can we ensure adequate hydration? You should be familiar with all the side effects of the drug, because of monitoring, you may be doing it yourself, So you should know what is morphine, when there's toxicity due to morphine, like if there's a pinpoint pupils, or if they have got constipation, then are we giving the laxatives? So if you know all about these drugs, then you will become very, very proactive, and you will be assisting the team in a very positive way. So that is why we should know everything. We should not blindly follow the prescription written by the doctors, because doctors can also make mistakes, or they may inadvertently omit something, So it is very important to show that you also know what you are doing. So that is why it's very important to know all the side effects of these medications, and how, because one of the important things of the ladder is that you have to pay attention to detail. So any side effect is there, you should be able to detect it. Or if the patient has got, like not only the side effects, but is there a drug interaction, or is there, patient's weight, sometimes a patient is weighing only 30-35 kilos. In such patients, we cannot give the regular doses of the drug. You have to give it according to the body weight. So you have to just calculate and see whether the drug written is correct or not. There's no harm in going through the prescription to see whether it has been written in a proper way. So little things. And also, as nurses, you should know about the kind of psychosocial problem the patient is having. You see, they may be having insomnia, they may be having loss of appetite. And so by assessing the patient and informing the doctors, or, making sure that we are treating the patient in a holistic way, that is so important. It's not the physical pain alone that we are treating. We are treating also the psychological, the social pains, as well as the spiritual pain. Like I think in the next case that Rekha Kumari is going to present, we talk that lady has lost faith, you see. So that is a kind of spiritual pain that they are going through. That why am I suffering? Is it because of my past sins? Just yesterday, I met a gentleman whose daughter has got advanced cancer. And he told me, I might have done lot of pap, or I might have done lot of sins why my daughter is suffering. It's not true. So I told, no, it's not because of anything that you have done that your daughter is suffering. That is called spiritual pain. It can be not only in the patient, it can even be in the caregiver. Which father would like to see the daughter suffering with pain, right? So he's telling that probably I have sinned and that is why my daughter is suffering with pain, which is not true. No, we have to remove those misconceptions. So nurses have to see about the holistic treatment of pain, not just the physical component. Okay?
Thank you, ma'am. So can we move on to the case presentation, ma'am?
Yeah, yeah.
Okay. Rekha Kumari, over to you.
Yes, ma'am. Good evening, everyone. My name is Rekha Kumari from Prem Jyoti Community Hospital in Jharkhand, one of the unit of EHO hospital in Barharwa, Jharkhand. Today, my case presentation about the patient details. She has a 54 years old lady, and then she was diagnosed as multi-organ failure under is acute liver injury, chronic kidney disease, DM type 2, nephropathy, neuropathy, hypertension, altered sensorium, and systemic lupus erythematosus. Present complaints is like pain in abdomen, blurring of vision, giddiness, disturbed sleep, not able to walk, and weakness. Then history of illness, she had a history of diabetes and hypertension since 10 years ago. She admitted and got treatment from private hospital, and she was diagnosed as chronic kidney disease along with the diabetes and hypertension. She is on medication of diabetes and hypertension. She advised for kidney dialysis. Then history of abdomen pain, constipation, oliguria, altered sensorium. And she had fluctuation of blood sugar, sometimes have a high and low blood sugars. On examination, she was conscious and oriented with person, not in time and place. Vital signs, temperature is 100.3 degree Fahrenheit. Pulse rate is 94 beat per minute. Respiratory rate is 24 beat per minute. Blood pressure is 140 by 100. And then SpO2 is 98%. Then random blood sugar is 448 mg per dl, which is very high. Then on physical examination done, on examination, eyes are swollen and icterous, abdomen is distension, legs are swelling, and she was unable to wake. Treatment and significant investigation is given. LFT was done. ALT is 365.9 international unit per liter. And then AST is 496.1 international per liter, which is very high for her. Then alkaline is 966. TB is total bilirubin is 2.47 mg per dl, and direct bilirubin is 2.0 mg per dl, and albumin is 3.9, protein is 7.4. Then electrolysis is done. Sodium is 126, potassium is 3.4, chloride is 1.28, ionized calcium is 4.2, normal calcium is 0.2, and pH level is 7.4. Urine routine, albumin is 1 plus, sugar is nil, uric acid done 6.2 mg per dl. Psychological aspects, 50 years old married woman living, with her husband in an own house. She has 5 children, 2 sons and 3 daughters, and they were living separately and not caring and helping them. Her husband was missionary and he used to take care of his wife. He was the breadwinner. Then patient was not willing to accept her medical condition. She was very depressed on examination as none of children were supporting financially and mentally. Sometimes she mentioned that her children loved her, but they couldn't visit her as they were living far away. She said that she didn't feel hungry, means loss of appetite, and she had stopped praying, and she told her that she doesn't have faith in God now. And then on observation, she had a sleep disturbance. Her husband was caring, but due to the patient altered sensorium, her husband also got frustrated sometimes and he used to scold her sometimes. She had feeling of isolation and hopelessness is there. Medication, analgesic drug, antibiotic drug, broad spectrum anti-infective drug, anti-diabetic drug, anti-hypertensive drug, sedative drug. Due to fluctuation of blood sugar infusion in injection, human ectrabid 1 ml per hours is given because of fluctuation of blood sugar level. Then intravenous fluid to maintain the electrolytes and to prevent from dehydration, we have to give the RL and NS. Then in analgesic injection PCM 900 mg IV Q8 hourly is given. Injection diclofenac 75 mg IV PRN. Then injection piptas 4.5 gram IV Q8 hourly given. Tab metformin as her blood sugar level. She has a diabetes and she has a hypertension. So she is on medication of tab metformin and tab amlodipine. And then because she is ultrasensorium and she is not feeling insomnia is there, that's why we have to give injection midazolam 5 mg IV PR as she irritated then. Main concern is there. We have to see the pain. It's mild, moderate, and severe. Then not ambulated, chances for bed sores because she is not able to walk. Then diet, especially diabetic diet, we have to see. Then emotional unstable, financial problem, spiritual support is very important for her. And then disturbed sleep and intake and output monitoring because she has a CKD. Then summary is there. 54 years old married woman living with husband in an own house. She had a history of diabetic and hypertension since 10 years ago, and she had on medication and treated private hospital. Later on, she was diagnosed as chronic kidney disease. Along with the diseases, she referred from kidney dialysis, and she had a financial problem. She doesn't go to dialysis because she has a financial problem. After that, she falls sick and she admitted again, and she was diagnosed as multi-organ failure. Medical treatment given to her and discharged, and she had a hypoglycemia. Before going home again, she had a high and low sugar level. The family didn't have money to go for dialysis, so our unit, we decided to stop treatment and give symptomatic relief. After that, she died after 2 weeks. Then I have a discussion points on this case. Do we need to provide palliative care for this patient? How we can support to the patient and her husband? Do you think that patient doesn't have faith in God because of her disease condition? Thank you.
Thank you, Rekha, for the wonderful presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points.
Rekha Kumari, can you mention what the kidney function reports are? You mentioned the liver function and also the electrolytes, but what is the serum creatinine and blood urea report?
Yes, ma'am, of course.
Because she is having renal failure, no? That is why I'm asking that.
Creatinine, done, its value is 12.0.
Which one? Creatinine.
Yes, ma'am. Serum creatinine.
That is very high, no? That is why she's.
Okay, we can move on to the discussion points. So do we need to provide palliative care for these patients? We'll expect reactions from the participant side. Do you think this patient need palliative care? Yes.
I think everyone is agreeing that she requires.
Yes, yes. So, if
Can
yes,
you elaborate? Can you elaborate how
yes.
you want to give
Yeah,
palliative?
yeah, okay.
Can anyone elaborate what all we need to take care of her?
So please unmute yourself and talk.
No answers coming. So whenever you want to give palliative care, you please remember what Dame Cicely Saunders talked about, total pain. Okay. So if you remember that, it is very easy to apply that and see how you can provide palliative. So we have to look at the physical part, the psychological part, the social part, and the spiritual part. So that puts the whole case into perspective. So in physical part, she didn't have pain as such anywhere, but she had multi-organ disease. She had got advanced renal failure. She had a liver injury, and she also had a heart problem as well. I think so, na? Hypertension. I don't know whether she was in heart failure, but she definitely had a multi-system involvement. She was icterus also. She was having icterus also. She didn't have pain, but she did have insomnia issues. And of course, unable to walk. She had swelling. So there are so many physical problems that she had, which is being treated by the by the physician in charge of the patient, right? She's been treated for her diabetes, for uh, her maybe pedal edema, they may be giving something, whatever. So that part is being taken care of, physical part. So now let us move on to her. But one thing I noticed is it was written diclofenac sodium in this lady, which I think should not be given because she's already having renal failure, right? Injection diclofenac 75 mg. So that is not to be given in the drug because diclofenac is avoided in patients with any renal dysfunction. So that we have to remove from that. Yeah. Okay. Now let's come to her psychological issues. So can anyone tell me what are the psychological problems that this lady is having? Was there anxiety? Was there depression? Was there fear of the future, insecurity? And insomnia could probably even be because of the depression and anxiety that she's having. So that could also cause insomnia.
Then
She could
low
have been,
salt.
she was very hurt because her children are not looking after her. Yes, right. Any other psychological issues that lady will be having? Yes, any more? See, I can see a sense of hopelessness, a sense of isolation. She's, yeah, exactly. So she also had a sense of hopelessness and isolation because she was with her husband having 5 children. No one was there at her when she really needed them. So these are all a psychological. She might have been even angry also, because of all this. So these are some of the psychological issues. So we definitely have to give her something to treat her anxiety and depression, and also probably counseling. Psychological counseling has to be done for her. Yes, she had frustration also. Frustration was actually her husband was getting frustrated with her because she was having an altered sensorium. Now, the social issues that she had. What were the social issues? Can anyone elaborate on that? Financial, that's a social issue, right? She had no money for the dialysis. So they had to even stop the treatment. Yeah. Isolation, that is also a social issue that she had was isolated, feeling isolated. Her own family, the children whom she cared for are not caring for her when she needs it. That's a social issue also. Any other social issues? Psychosocial issues can be sort of sometimes even combined together. Because social issues can lead to psychological problem, and psychological issue can cause social issues. And then there were spiritual issues. Okay. That is, she had stopped having faith in God. She stopped praying. So there are a lot of kind of pain that she was going through. And when you look at palliative care, you need to treat it holistically. You need to address all these. Okay. So for that, besides treating the physical part, you need to put her on medications, need a good psychosocial support. You may not be able to reverse a lot of things, but you can at least tell her that we are there with you in your journey. And maybe convince her husband to be a little kinder to her and not get frustrated because of her altered sensorium. Okay. So we need to address all these issues. Shobha, Shiba, any other things you would like to add?
No, ma'am. This much. If possible, we can get NGO support, like community support, local social support, and all. And I'd ask one question about her relatives, her own brother, sister. Did she get any support from them? That relatives, not maybe these children are not supported, but what about their other relatives, brothers? Does she has any brothers and sisters? Rekha? No, don't know. Leave it. So just try to, yeah. Rekha, you want to say something?
Yes, ma'am. But he has a missionary
Okay.
from the church, but not much more than. That's
Sure.
Even the church can give her support, you know.
Yeah.
But they are caring for the church members. So when they are in problem, the members also should be able to give her some kind of support.
So volunteer support. So
Yes.
if they are alone, we can seek volunteers help, and the volunteers can help a lot with this type of patients. Give a psychological support, and if we can able to prevent the isolation, no loneliness. Also, we give if the volunteers are willing to talk to the this type of patients, we can try to solve this type of isolation and all. So.
Any other, what are the other points that need to be discussed?
Any other things? This much. The third question, do you think that the patient doesn't have faith in God because of her disease condition? What do you think? Yes, ma'am.
It is not alone the disease, but the other things also that have made her lose faith in God, I think. The psychosocial concerns also. This disease is only part of it, but her overall things like feeling of desertion, isolation, all
Yes.
that may have also contributed to her losing faith in God. So we have to counsel her appropriately. You know? And if her husband is a pastor, he's the best person to counsel her.
Yes.
On these spiritual matters, he can counsel.
Yes. So and the other thing is, if they have a so as I said last week, if they have a psychosocial issues, psychosocial spiritual issues, they definitely their physical distress will be increasing. So as ma'am said earlier, total pain assessment and give a proper treatment. 4 aspects treatment is big here for achieving the goal, because we are trying to improve the quality of life of the patient and the family. So if we need to achieve that quality of life improvement, definitely we need to assess the 4 aspects: physical aspects, psychological aspects, social aspects, and spiritual aspects. If they have a psychosocial issues there, you can give proper counseling and psychosocial support. If we are able to relieve their psychosocial issues, try to solve their problems. For example, if her main problem is here, this patient story says her main problem is their children's no not willing to see her. We have to identify the cause why they are not reluctant to see her. If they have any problem there, we can try to solve their problems. So if you talk to them alone, so definitely they will understand the mother's request and that things. They are usually they will accept and come and see that patient. We have a lot of experience like that. If initially they are not willing to see that mothers or fathers and sister and all, so after counseling, after meeting with the after a small meeting, they have decided to see their her mothers or his mother, father, and all. So the thing is that there will be a lot of problems, but we can, if possible, we can try to solve their problems. So anybody wants to add anything or comment on anything on this patient story, please unmute yourself and talk. Otherwise, we can wind up the session.
See, I mentioned about nurses being proactive. So in that prescription, when diclofenac sodium was written, maybe as a nurse, you could have told the doctor that I think it's diclofenac is better to avoid it. I think you can speak up, you know, but this was obviously written by a doctor, but maybe at that point of time, it didn't occur to him that he should not write it. So as nurses, if you have the knowledge, no, then see what the mind does not know, the eyes will not see, right? So if you have the knowledge that diclofenac is contraindicated in patients with renal failure, then maybe this could have been pointed out to the doctor.
That is true, ma'am. So we need to improve the knowledge.
Yes.
And we nurses have a lot of skills, but I think we need to improve our knowledge also. We are not a person for carry out the orders. We should tell the things like this. Madam said, if this is not a suitable drug for that particular situations, you have to talk to them freely. It's not instruct. You just I have read like this is this is not a good drug for these patients. What do you think, doctor? Like that.
Yeah, put it in a very diplomatic way.
Yes. Okay, thank you, ma'am, for the excellent session. It was a nice session. We have learned a lot. Thank you, Rekha Kumari, for an excellent presentation.
Yeah.
Thank you. Thank you all for your contributions and see you next time. Thank you. Thank you, ma'am. Happy to see you.
Same here.
Okay, ma'am. Thank you. Bye.